Sorry about that. So today, again, let me kind of go back for you guys just so that we understand. We are doing case study number 12. Patient is presenting with hypotension. All right. I apologize, guys. Again, medical disclaimer here. These cases that we're talking about here are not, someone said morning coffee. Zach, you're fired. I know. I'm sorry, guys. I'm not that good with technology. All right, so the cases we're presenting here are fictitious. They're not real. They're for educational purposes only, okay? To help us to go through our differential, help us to think thoroughly about conditions and how to treat them. Thank you, guys. Sorry for that mistake. I apologize. All righty. So we have a patient coming in. The overarching theme is hypotension. But let's see how this patient comes in. So the person is a 71-year-old male with a past medical history of coronary artery disease, mitral regurgitation that presents to the Ninja Nerd Clinic feeling just very weak and lethargic. About a week ago, he underwent a 2-vessel coronary artery bypass graft. And while they were in doing that, he also had a mitral valve replacement where they put in a mechanical valve. He does deny any nausea, any vomiting, any diarrhea, cough, painful urination, urinary frequency, abdominal pain, fever. You can go through the entire list. His 14-point ROS system is negative. Okay. So again, to kind of recap, 71-year-old male, past medical history, coronary artery disease, mitral regurgitation, just had a CABG, 2-vessel CABG about a week ago, and a mitral valve replacement, comes in feeling very weak. Got it? All right. We walk into the room. When we walk into the room, we look at the screen and we see the vitals as presented. Their heart rate is 130, so they're tachycardic. Their respiratory rate is 22, so just slightly on the tachypnic side. Their blood pressure is 85/65, okay? And this could be the cuff pressure. This could be a arterial line pressure. We don't really know yet. Let's just assume it's a cuff pressure. The temperature is 101.4, so the person is kind of febrile right now. Their SpO2 is 92%. Okay, 92%. So they're not really hypoxemic. Cardiovascular-wise, the person is tachycardic, as we can see. When we're listening to the heart, we can hear their heartbeat really, relatively fast. They have a normal kind of S1, S2. They have a regular rhythm, so it's not irregular. But when you're looking at their jugular vein, you notice that it's distended. It's kind of plumping up during the inspiratory process. When also you're listening to the heart, the S1, S2, it sounds like really, really distant. Like you can barely hear the S1, S2. You can hear the heart beating really fast, but it's really kind of like a very diminished heart sound. Okay, so they're tachycardic. They have a regular rhythm. They have JVD. They have very diminished heart sounds, S1, S2. And another thing you notice is when you're looking at the actual monitor, you see that their blood pressure, or their pulse actually, let's say, you see that their pulse it has a variation of 12 millimeters of mercury during inspiration. Okay, so you see that their pulse actually has a variation during the inspiratory process. Okay? Pulmonary wise, you're listening to them. They look like they're tachypnic, so they're breathing a little bit faster. When you're listening to the lungs, you do hear some crackles, some rales bilaterally. And whenever you had them kind of laid flat, they really complained of some shortness of breath. Okay? And then abdomen, it's soft, it's non-tender to palpation, normal active bowel sounds. So again, 71-year-old male, past medical history, CAD, mitral regurgitation, just had a 2-vessel CABG about a week ago, coming in feeling weak. Tachycardic, tachypnic, hypotensive, febrile, decreased heart sounds, JVD. What do you guys call, let's test your knowledge here. Oh, someone already beat us to it. Morning coffee pottery is too good. You did it. You done did it. All right, yep, that was the question I was going to ask. What do you call it whenever there is a variation in the pulse during inspiration of greater than 10 millimeters of mercury? And you done did it. You got that pulsus paradoxus. Great job, morning coffee pottery. Outstanding. So yeah, that's what it's called, pulsus paradoxus. So we have tachycardic, tachypnic, hypotensive, febrile, decreased heart sounds, JVD, pulsus paradoxus, some crackles, some tachypnea. And so what is it called when they have shortness of breath when they're lying flat? What is that called? What is that called, guys? Whenever you have a person who has shortness of breath or dyspnea whenever they're lying flat. What do we got, ninjas? What do we call that? Anybody know? Orthopnea. Great. Awesome. You guys, now it's all flowing in. Beautiful. Yep, orthopnea. Outstanding. All right, cool deal. All right, so another question for you guys, and some of you guys already hit it in there because you guys are so darn smart. What is it called when you have a person who is hypotensive, jugular venous distension, and decreased or diminished heart sounds? What is that called? There's a particular triad, if you will. I saw it was mentioned a couple times in there. But it's a particular triad whenever you have a person who is hypotensive, jugular venous distension, and diminished or decreased heart sounds. And just a quick thing, Mohammed, technically that's not wrong. Paroxysmal nocturnal dyspnea is you're lying flat when you're sleeping, so you have shortness of breath like during the night while nocturnal. So it's a kind of a temporary or transient shortness of breath usually when you're lying down flat when you're sleeping. But yeah, it's kind of like that type, but usually it's just orthopnea as you're kind of laying flat. Yep, Beck's triad. You guys are awesome, man. You guys are so darn smart. All right, cool. 71-year-old male, CAD, mitral regurg, had a bias, tachypnic, crackles, orthopnea. Okay, man, we're good. What is your suspected diagnosis? If you had to pick from these particular types, I want you to tell me which one of these is your suspected diagnosis. So I just want to see, first off, before we kind of go through each one of these and try to figure out why this one shouldn't really be this, top diagnosis, why this one shouldn't be considered, why this one shouldn't be considered. I want to see what you guys think is the number one diagnosis at this point in time. All right, maybe I made this one too easy, or you guys are just so darn smart. Probably the latter. Yeah. Yep. So we got cardiac tamponade, some decompensated heart failure. I love it. All right, cool. So we got kind of a little bit of a mixture. It's kind of like the most prominent one is cardiac tamponade, but there's a little bit of decompensated heart failure in there as well. Okay. All right, let's go through this. Let's think through it. Let's use our brains, right? So if you have a patient with a tension pneumothorax, they can present with some of these symptoms, right? A tension pneumothorax is they develop some type of air within the pleural cavity. The air in their pleural cavity increases the intrapleural pressure to where it becomes greater than the intrapulmonary pressure, and then it starts pushing on the lung, compressing the actual ipsilateral lung, and then smashing it and trying to shift the mediastinum towards the contralateral side. And when it does that, it can compress on structures like the superior vena cava, it can compress on things like the inferior vena cava, it can compress on the right ventricle. So in a patient with a tension pneumothorax, here's my question for you guys. Could they have JVD? Could they have pulsus paradoxus? And could they have hypotension? Can a patient with a tension pneumothorax have those three things? Hypotension, JVD, also tachycardia. Could they have some of those things? And pulsus paradoxus? Patient with a tension pneumo. Yeah, they can. Absolutely. Yep, definitely. So it's a possibility. If they have a good enough shift, they definitely can do what? Compress on the superior vena cava. The superior vena cava drains what structures? Your brachiocephalics. Right? So you have your brachiocephalics, your left and right, and then from those, they drain into the superior vena cava. From the brachiocephalics, you have your IJs, And then you have your subclavians that are coming together to make the brachiocephalics. So if the superior vena cava is getting compressed, it's going to cause it to back up and cause jugular venous distension. If you are compressing onto the superior vena cava and the inferior vena cava, you decrease preload to the right ventricle, which will decrease the preload to the left ventricle, causing hypotension. And if you cause enough compression of the right ventricle, you cause the septum to bow into the left ventricle, obstructing the outflow tract of the left ventricle, particularly during when? Inspiration. So the pressure will drop in a patient who actually has this tension pneumothorax. When they're breathing, their pulse will drop or their pressure will drop during inspiration. So you can see signs of pulsus paradoxus. They could even have tachypnea as well. So a lot of the things could be a tension pneumothorax, but what's one of the things that we should be obviously listening to? What is one of the things from our exam that we did not have that would be evident of a tension pneumothorax? Simple thing, use your stethoscope, and what would you potentially find on physical exam for a tension pneumo? Maybe it's not just stethoscope, maybe it's something else. There's two common things that you could just quickly say, yeah, man, you guys are good. Absolutely. Menorah breath sounds. Jawad, you could definitely do percussion. I like it. All right, so let's say you listen for breath sounds. Obviously, there would be decreased breath sounds. Okay. If you were to percuss, okay, then you would get a hyperresonant type of percussion. What would you get if you did tactile fremitus? You put your hypothenar imminence on their chest wall and said, say 99. What would you get if you did that? If you did tactile fremitus? So you get decreased in that we're doing this in the clinical practice, but for your exams, you should definitely know this. Yep, decreased tactile fremitus because the air is kind of blocking the ability of that sound waves to pass from the chest wall to your actual hypothenar imminence. So you should have a decreased tactile fremitus on that patient with a tension pneumo. So right away, can we say that we have a low suspicion? Not a low suspicion, but the patient didn't have decreased breath sounds. They had decreased heart sounds, right? We didn't notice any hyperresonance on percussion. We didn't notice any decreased tactile fremitus. And another thing is, sometimes if it's significant enough, they can have tracheal deviation too. We didn't appreciate any tracheal deviation. So I'm saying that tension pneumo is a possibility because some of the symptoms and clinical features they have is potential. Plus, they did have a cardiac surgery. There's always the potential when they had that cardiac surgery, they could have caused a pneumo. And then the pneumo just is built over time, over this past week. It's a possibility, okay? But it's kind of on the unlikely side. Okay, usually if it was to happen, it's usually a person, we have the primary spontaneous pneumos, the secondary spontaneous pneumos. So the primary would be a young, tall, thin male, usually Marfan smokers. This isn't that guy. Secondary, they would have like COPD, they would have asthma, cystic fibrosis. They would have some type of like infection of the lungs or TB or cancer, or they would have some type of trauma. Could it have happened during a traumatic event during the surgery? It's possible, but it's a low likelihood, but we'll still keep it on the table. All right, everybody good with that? All right, so let's go through massive PE. Massive PE, can it cause hypotension? Can it cause tachycardia? Is there a possibility of it causing pulsus paradoxus? Is there a possibility of a person having tachypnea, tachycardia, maybe even some JVD? Is that all possibilities? I'd say so, right? If they had a pretty big enough PE, if they had a big enough PE that's blocking near the actual pulmonary trunk, a saddle embolus, what's that going to do to the right ventricle? It's going to put pressure on the right ventricle, right? Because the pulmonary hypertension. You put pressure on the right ventricle is going to dilate. If the right ventricle dilates and now it's going to become dysfunctional, then what's going to happen? The cardiac output from the right ventricle to the left ventricle decreases. So then you end up with hypotension. Reflexive reaction from hypotension is tachycardia. If the right ventricle is failing and you have a big enough failure, what happens if you have right side heart failure? It backs up via the superior vena cava, inferior vena cava. So it can cause JVD, and it can cause some maybe potential like lower extremity edema, hepatosplenomegaly, right? And if the right ventricle is dilated enough and it's having to work so hard that it's actually getting so big that it's pushing on the septum to the opposite side into the left ventricle, it can cause pulsus paradoxus. And they can have hypoxemia. Did they have hypoxemia? Not significantly, but their O2 sat wasn't great. So it's like, frack, man, I don't know. They could potentially have a PE. Generally, PEs, they have shortness of breath. This person had shortness of breath when he was laying flat. They also have tachypnea. So it's still tough, but we got to think about what would be some risk factors. Does he have any risk factors for developing a massive PE? Is there any particular risk factors according to Virchow's triad that this person has a risk of a PE? Anything specific? Surgery. Yep, minority. Yeah, he got it. Yeah, it's surgery. He had surgery. Any kind of surgery, there's endothelial injury, right? That's one thing. Plus, if he was having to kind of like stay immobilized in the hospital after he had surgery, or kind of had bed rest at home, or he didn't have a lot of opportunity to ambulate, there's definitely a potential for him to have a PE. It's possible, right? So, man, tension pneumo is a possibility. Massive pulmonary embolism is a possibility. Oh, okay. What about cardiac tamponade? Cardiac tamponade, what's a risk factor for him? Does he have any risk factors or any kind of like thing that could have happened to him that could have caused cardiac tamponade? When they were fixing the mitral valve, they perforated a part of the ventricular wall. Could have been. He does have some risk factors for cardiac tamponade. Cardiac tamponade, it can cause hypotension, right, guys? It can cause tachycardia. It can cause JVD. It can cause pulsus paradoxus. What's something else that it can do? If you get a lot of like fluid or blood in the pericardial cavity, though, a lot of fluid and blood in the pericardial cavity, and you're listening to their heart, you have to have the heart sounds be transmitted through the wall of the heart, through the fluid in the pericardium, through the chest wall. So what would happen to those heart sounds? You would get decreased heart sounds. Ooh. This person had hypotension, they had tachycardia, they had JVD, they had pulsus paradoxus, they have tachycardia, and they have decreased heart sounds. Holy crap. And they had risk factors for cardiac tamponade. This is a possibility. Does it explain their tachypnea and their crackles? It could. Because if a person had a significant amount of cardiac tamponade, where you're actually squeezing on the heart and you're strangulating the heart and decreasing the ability of the blood to enter into the heart, left ventricle and right ventricle, you decrease the filling into the left ventricle, fluid can back up into the pulmonary circulation, hydrostatic pressure increases, and it starts leaking out into the interstitial spaces. And then you start developing pulmonary edema, which can cause tachypnea and a little bit of hypoxia. Oh, cardiac tamponade is definitely a possibility, guys. Alrighty, you guys are getting annoyed. I can tell. It's like, I don't know what it is, Zach. What about an N-STEMI? Is this a possibility? I'd say so. He's got a pretty significant heart disease, right? He had to have a cabbage, for goodness sake, for a coronary artery disease. Sometimes you can develop MIs after a cabbage. There's a possibility. He definitely could have an N-STEMI. Does he have any chest pain? We didn't say any chest pain. Generally, they could have tachycardia. They could have hypotension if they had a good enough chunk of the heart taken out. A good enough of the heart actually did undergo an infarction. Then you lose a good chunk of, especially if it's left ventricular. It wouldn't explain like any JVD though. Wouldn't explain that. Wouldn't really cause any pulsus paradoxus. I don't know. I'd say N-STEMI's on the lower end of the list, even though this person has a significant coronary artery disease and cabbage. They don't have any chest pain. I don't really think that the N-STEMI and STEMI would explain them having any kind of JVD. It wouldn't really explain them having particularly any of that kind of symptoms or pulsus paradoxus. It could explain hypotension. It could explain tachycardia, and they definitely could explain the pulmonary edema. but it doesn't explain the decreased heart sounds, right? So I don't know. I'm leaning less on the N-STEMI STEMI. All right. Decompensated heart failure. The person, did they even have heart failure previously? They could have. It just wasn't maybe mentioned in their history. Maybe that wasn't completely diagnosed recently. But if this person had coronary artery disease and they took a big chunk out, let's say that they infarcted a good chunk of their left ventricle, and now their left ventricle is weak. Now they have systolic heart failure. What can happen in systolic heart failure? Well, their ability to eject blood out of the left ventricle can decrease. That can cause hypotension. They can have a reflexive tachycardia. If the left ventricle isn't contracting and putting blood out of the left ventricle, it can back up into the left atrium, pulmonary circulation, cause pulmonary edema and tachypnea and a little bit of hypoxia. Could it explain the decreased heart sounds? Not really. It shouldn't. It shouldn't cause decreased heart sounds. And JVD, it is a possibility. And the reason why is if left-sided heart failure progresses to right-sided heart failure, then the right side heart can fail, and then that can cause the JVD potentially. The pulsus paradoxus, probably not. That's on the lower end of its ability. Okay? So I would say, and if you guys agree with me, I would say tension pneumothorax, massive pulmonary embolism, and cardiac tamponade are, I would say, on the higher end of this differential, whereas N-STEMI, STEMI, and decompensated heart failure on the lower end of the differential. Would you guys agree with this kind of thought process and logic that we've got? Oh, thank you, dear. That was very, very sweet. Thank you so much. All right, so you guys agree. Minora Rathora agreed. Anybody else have any other questions before we move on to this next part here? Okay, cool. All right, so I ask you guys, I pose the question then. Tension pneumothorax, massive pulmonary embolism, and cardiac tamponade all fit into what kind of category in a person who has hypotension? What is that category? There's a particular, I'm going to say the word shock. What type of shock does cardiac tamponade, tension pneumothorax, and pulmonary embolism fit into? What do you guys think? All right, so some are saying cardiogenic shock. I would think about it. Think about it a little bit. There's cardiogenic shock, there's septic shock, there's, there's technically hypovolemic shock, cardiogenic shock, and there's distributive, obstructive shock. So an obstructive type of shock is what this one would be considered, because you're obstructing the outflow of blood, particularly either from the right ventricle or from the left ventricle. So it's an obstructive type of shock. So tension pneumo, massive pulmonary embolisms, and a cardiac tamponade are examples of what's called obstructive shocks. Okay? Whereas N-STEMI, STEMI, and decompensated heart failure would be more of an example of a person with cardiogenic shock. Okay, cool. So we have the test that we want to start running then, right? So for a tension pneumo, a massive PE, a cardiac tamponade, and N-STEMI, STEMI, decompensated heart failure, these I think would be the big tests that you guys need right away, right? Would you guys agree with these tests here that we have? A 12 lead EKG in troponins, a chest x-ray, a point-of-care ultrasound. That could get us started at least. Would you guys agree with that? Is there any other kind of test that you would say is definitely needs to be on this list, like it has to be the most emergent one? Or is there any other test that you guys think should be on this? Because then what we'll do is we'll go through these tests and say which one, like why these tests should be included somewhere else. Okay, so you guys agree. All right. So 12 lead EKG in troponins, that's going to tell us, first off, it's going to help us with which part? The N-STEMI and the STEMI, right? It'll tell us if we have any ST segment elevation, any ST segment depression, any kind of hyperacute T waves, inverted T waves, anything that could like lead us off to thinking about an STEMI. And then we can use our troponins and correlate it with our EKG, right? Now, troponins also could be elevated though in a massive PE. So we got to be careful, and we could also have other things that are common on a 12-lead EKG for massive PE. What is the most common? I'm asked two questions. What is the most common EKG finding in a person with a massive pulmonary embolism? And then second question is, what is the classic, the textbook finding on a 12-lead EKG with a massive pulmonary embolism? So two questions. What is the most common finding? Second, what is the classic finding, your textbook finding for pulmonary embolism on a 12-lead EKG? Man, Denton, you're on the ball, man. I love it. I was going to get to that. You beat me to it, Denton. All right, so S1Q3T3 is your classic finding. Some of you guys are putting that in there. So S1Q3T3, right bundle branch block, right axis deviation. Those are your the classic findings for your exam. The most common finding is actually sinus tachycardia. Okay? The most common finding is sinus tachycardia. Don't forget that. Denton, who beat me to it, that son of a gun, he's too quick. Another thing about the 12-lead EKG, and we'll talk about what that would look like. We'll explain that in a second. The other thing it could show is low voltage QRS complexes, right? So that's another thing that 12-lead EKG could tell us is electrical alternans, or what else? Low voltage QRS complexes. Margaret, yeah, Denton's good every week. He's a smart guy. All right. I think we're good. I think we got an idea here, right? So the 12-lead EKG can help us look for ST elevation, depression, inverted T waves, hyperacute T waves, Q waves. S1Q3T3, right bundle branch block, right axis deviation for classic findings of PE. Sinus tachycardia for the most common finding of a PE. Cardiac tamponade, low voltage QRS complexes, and electrical alternans. Boom, shagalaga. Let's move to the next thing, the chest x-ray. What's the chest x-ray going to help me with? Smack dab right here, the first one. Tension pneumo. Now, you shouldn't ever wait. If you have a suspicion of a tension pneumo, you treat it immediately without waiting for a chest x-ray. But if you're on the lower end of you don't know if it's actually a tension pneumo, you can do a chest x-ray. Right? So a chest x-ray would show us what? Loss of any kind of vascular markings. Maybe we see a pleural line. Maybe we see a widening of the costophrenic angle. So definitely a possibility there. For a PE, a chest x-ray, the most common finding is what? Here, oh, this is a great question. What is the most common finding on a chest x-ray with a person with a pulmonary embolism? Common finding on a chest x-ray of a person with a pulmonary embolism. Morning coffee pottery. It's the textbook answer, Westermarck sign or Hampton's hump. But it's very rare that you'll see that. I want to see if somebody says it. So someone said Westermarck. We got the Hampton's hump. Again, those are the textbook answers. You rarely ever see them. All right, I'm going to blow your mind. Normal. A normal. Yeah, Margaret. You're a beast, Margaret. Awesome. The most common finding of a person with a massive pulmonary embolism in their chest x-ray is it's normal. So that should cue you off. A person who's dyspneic, they're tachypnic, they're hypoxemic, they got a normal chest x, popping it out. Awesome. You guys are great. Okay. In a cardiac tamponade, you'd see a big old fat water bottle shaped heart. All right, and same thing with decompensated heart failure. You'd see a big old cardiomegaly, right? So you see cardiomegaly for a decompensated heart failure. You see also some cardiomegaly, or particularly like a bottle-shaped type of appearance for cardiac tamponade. Okay, point-of-care ultrasound, which is the last test here. And then we're going to look, and you're going to tell me what you see, and then we're going to make the diagnosis. And then we're going to treat this person quickly. Okay, point-of-care ultrasound. For a tension pneumo, what would you use on the point-of-care ultrasound? So if I'm slapping the ultrasound on the person's chest and I'm thinking that they have a tension pneumo and I'm going through all of these spaces, what am I thinking of potentially popping up? So again, I slap the ultrasound on the chest. I'm going between the rib spaces. I'm looking for absence of blank. What are you guys thinking? Oh, I'm sorry if the internet's not working great today, guys. I apologize. Oh man, yes, good. Someone said barcode sign. Yes. And someone said sliding. So absence of sliding. Absence of lung sliding is what you would see potentially on a pneumothorax. Normally, when you have an ultrasound, okay, and you're putting it on the chest wall, you see this very bright, thick pleural line, and it slides with each breath. If there's an absence of sliding, that means that at some point there's a break between the visceral pleura and the parietal pleura, and it's not actually going to be sliding. So that is one of the common findings on a tension pneumothorax if you slapped an ultrasound over it. A subxiphoid view or a apical four-chamber view for the ultrasound will show a what? For a massive PE, showed a dilated right ventricle, decreased contraction of the right ventricle bigger than the left ventricle, dilated IVC, dilated right atrium, a lot of those signs. Okay? Cardiac tamponade, a point of care ultrasound is key. You throw a subxiphoid view on, and you're going to see a big old cavity, anechoic space filled with fluid or blood around the pericardium. Okay? And that could be a sign of cardiac tamponade. And STEMI, potentially you can see what? Wall motion abnormalities. So if you throw an echo over there and you see one part of the heart is actually not squeezing as well as another part, they could have a wall motion abnormality, and that could be potentially related to them having an NSTEMI or a STEMI. So I think we got a good idea of what these tests are telling us. Now what we can do is we can go ahead and move on and look at what the test results were. All right, Ninja Nerds. So we got here a patient's EKG. It came back. When we get the EKG, this is what we see. We also, I'm giving you their tropes. It was 0.12, 0.15, and then the third one was 0.13. So it's not too high. The tropes aren't high, really. It's a little bit of a troponanemia, a tiny little bit of a troponanemia, nothing crazy. And also the good thing is if you follow the trend, the first one is 0.12, 0.15, and then it went back down. So there's a downtrend of the troponin, which is a good sign. Oh man, you guys are good. So people are saying low voltage EKG. Yep. Yeah. So you can look here in 1, 2, 3. Look at the low voltages. Okay. Definitely some low voltage here in that 1, 2, and 3. Remember, you guys can add these up. Okay. And you could add up V1, V2, V3. But yeah, definitely it's super obvious. There's no ST elevations. There's no ST depressions. I don't really see any kind of deep S wave in lead 1. I don't see any Q wave or inverted T wave in 3. I don't see any right axis deviation. I don't see any right bundle branch blocks. I don't see, again, any signs of ST segment deviation. But I definitely would agree that there are some low voltages here in 1, 2, 3. And what else do you guys see? Look here on the rhythm strip, lead 2. R wave is right here. About, let's say, 5 to 7 millimeters. Come over here to this next R wave. Less than that. I don't know. Maybe it's like 3, 4. Okay, 3, 4 millimeters now. Come over this this one over here. Back up to about 7, 8. Back down to about 4. 8, 4, 8, 4, 8, 4. What is that called? Electrical alternans. You guys are great. Yep. Man, you guys are so darn smart. So we got a person with low voltage QRSs, a troponins that trended up but then trended down, low voltage QRSs, and electrical alternans. You guys are already starting to think about what this person has. Let's go to the next thing. Here's our chest x-ray, baby. What do we see on the chest x-ray, guys? If we look at this chest x-ray, We got here the right hemithorax, left hemithorax. You can see the trachea. It's right here, and it's kind of staying midline, branching off here into your right and left primary bronchus. You see this right hemithorax. It's a little bit more opacified. Looks a little like edematous, like interstitial kind of edema here, pulmonary edema here. Costophrenic angle is a little blunted. It's not nice and crisp like you would compare over here. This side's a little bit more loose, not as opacified. A little bit more of a hyperlucency in comparison to this side. But you got pulmonary markings that's going all the way out to the chest wall. So I don't see any signs of a pneumo here. But I definitely got a little bit of edema, right? And some pulmonary vascular congestion. But look at this son of a gun. Holy mama. That's a big old heart. The way that you can compare this is if you take and you actually use your fingers, right? And you measure the heart, right? You take your fingers and you measure your fingers with the heart, and if it does in this hemithorax. So this person has a cardiomegaly, and what did I tell you? It's kind of like a water bottle kind of thing. It's a really kind of like weird looking shape. So I'd say they have some pulmonary edema. That explains their crackles. That explains some of their tachypnea. That may explain why their O2 sats were a little bit lower. And they have cardiomegaly. Whew. So we have an understanding why they have that crackles, tachypnea, hypoxemia. We know they have cardiomegaly. We know they have electrical alternans. We know they have low voltage QRSs. Cardiomegaly, pulmonary edema, right greater than left, no pneumo. Here's our point of care ultrasound. Oh man, this person's not having a good day. He all jacked up. Look at this. Look at this. Will someone please look at this? Oh my gosh, look at all that anechoic space there. So if you guys see this large anechoic space, this is going to be, again, this should generally be like your left ventricle, left atrium, right ventricle, interventricular septum. This anechoic space, which is kind of spanning all the way around here, is a large amount of fluid within the pericardial cavity. Okay? Large amount of fluid within the pericardial cavity, and it's definitely enough volume to start strangulating the activity of the heart. So what do we have? Large pericardial effusion that's causing a cardiac tamponade. And if we did the ultrasound over we don't see any right ventricular dilation. Usually the right ventricle should be bigger than the left ventricle. Usually should there be hypokinesis. There wasn't any hypokinesis. And obviously when we were doing the ultrasound over the lungs, we did not see any kind of we did not see any kind of loss of lung sliding. So with that being said, we have a person with, what is the diagnosis? Cardiac tamponade. Likely secondary to them getting their cardiac surgery. When they got their CABG and their mitral valve replacement, there was probably some injury to the myocardium of the heart that caused them to leak some type of maybe blood or fluid into the area of the pericardium. Over time, it started tamponading, squeezing down on the heart, and then affecting the ability of all of the things that we just saw. It is impressive how significant this can be, right? So my next question is, what is the emergent treatment? This is the thing that's, you guys are like, all right, I already know what I'm going to do now. So what do we do to treat it? Yeah, so Margaret was like, drain that baby. Yep. I said back, he's like, who knew? Yeah, it might have been obvious the entire time. I might have drugged this one out, guys. I apologize. Just wanted to help you guys to understand, to reason through everything. But you guys are too smart. You don't need any help. Yeah, pericardiocentesis. Yep. So emergent treatment, if they're really, really hypotensive until you get them ready to start doing the procedure, you can give them some fluids. Just be cautious. You don't want to over stress that right heart. You can give them something to give some inotropic kick for a little bit, something like dobutamine or milrinone. And if their pressure drops, which can happen with dobutamine or milrinone, you can throw them on a vasopressor. But this is just something to temporize them until you can get the ultrasound, or you can get some type of guidance, whether you're doing it emergently without any kind of guidance or ultrasound guidance, getting your kit ready to start doing a pericardiocentesis. But the pericardiocentesis is going to be the big thing. Once you pull and aspirate off all that fluid and blood from the pericardial cavity, pulsus, paradoxus, and JVD, a lot of that should really resolve. Okay, so pericardiocentesis is going to be the best thing to do here in this scenario. Once you do the pericardiocentesis, it should fix the actual underlying issues that they've had from it, like the hypotension, like the tachycardia, and so on and so forth. But until then, you can put them on some fluids, maybe a little bit of an inotrope and some pressors until you get that done. If it continues to recur, which is a possibility, they then can have particularly a kind of a surgical treatment to prevent this from happening again, like a pericardiotomy or a pericardiectomy. Okay. So what could cause the fever? That's a good question. It could be, to be honest with you, it could be a lot of different things. It could be reactive from the underlying stress. There was no signs of infection in this kind of scenario, so I don't think that this is anything that we're going to worry about. It's probably just a reaction to like the sympathetic event. Sometimes if you get a good enough sympathetic event, this may cause like a little bit of a low-grade fever. Okay. So compressors make the tamponade worse. It could depending upon what you're trying to do. So if you're trying to if you increase the afterload on the heart, which can happen with something like phenylephrine, can happen a little bit with Levophed or norepinephrine, then there is a potential that you could increase the afterload on the left ventricle, which could make it harder for the left ventricle to increase its ejection fraction. So that's why you'd want to give something like dobutamine first. Dobutamine is more of an inotrope, so it's going to give you a little bit more of a kick, a little bit more contractility to increase the ejection fraction and push more blood out. And then if sometimes what can happen though is when you give dobutamine or milrinone, they're vasodilators as well. And so that could also cause them to lower their pressure. So usually vasopressors are an add-on if the dobutamine or the milrinone causes them to become a little hypotensive because of the dilatory effect of it. Okay. All right. So I think that covers everything, Ninja Nerds. You guys are so darn good. So now that we have finished this, we finished our case. We diagnosed the person with a cardiac tamponade. We treated it. We did a pericardiocentesis. We stabilized them temporarily with some things to monitor their hypotension, such as some fluids, inotropic medications like dobutamine or milrinone, and if they became hypotensive from those, something like a vasopressor. Okay, and then after that, you can do something like a pericardiotomy or a pericardiectomy. Okay, that's usually to prevent the recurrence of the disease in the future if it happens again. All right. Rameza Saeed, the cause of tamponade was uremia. No, it was likely from the cardiac surgery. It was likely from the cardiac surgery that caused the cardiac tamponade. Yeah, go watch that GCS video, Denton. That's awesome, Margaret. I've only seen one once, and it was pretty crazy. Alrighty. Well, I hope this all made sense, guys, and I hope that you guys enjoyed it. I hope it helped. Next week, we'll be back. We'll do another case study. We'll have some fun with that one as well. So, Ninja Nerds, thank you guys always. Until next time.